Mark, are you recording?
Yes, I am.
Okay, perfect. All right, so as always, each of these presentations, this information is confidential and privileged. It's protected under the HIPAA Act, and we should not be distributing it, copying it, or disseminating it in any other way. So moving on to our first case, this is of a 44-year-old woman that EMS had documented that she met them outside as they arrived. She was walking down the stairs. The patient had initially complained of nausea, vomiting, and some chest discomfort. When they arrived, the patient was alert, walking down the stairs. Her airway was open. She was protecting it. She appeared to be pink, warm, dry, and there was no obvious signs of bleeding. Vital signs were obtained right shortly after they arrived. Heart rate noted to be tachycardic at 106, blood pressure 123/75. No respiratory rate was documented for this initial one. The past medical history that she provided to the crews was that she had a history of anxiety, chronic back pain, obesity, and ventricular tachycardia, but I think that that may have not been present until the second presentation for her. Her past meds included baclofen, gabapentin, and oxycodone, and the history she provided them was that she recently started a new weight loss medication on the 1st of February that required her to inject it to herself. She had taken one dose and stopped doing that because she developed nausea, vomiting. She reports that she's been persistently nauseated and vomiting for the last couple of days following that administration, no associated diarrhea, and that at 1300 she started developing chest pain that has been progressively worsened. She had told them that she previously had a loop recorder implanted, I think a year earlier, and that although this loop recorder was implanted, she had destroyed the monitor. So there was no way to, from my understanding, to be able to identify any arrhythmias. So the 1 o'clock in the afternoon chest pain, it's now 8:34 when they made contact with her. Vital signs as reported initially. At 4 minutes, they did a 12 lead. I do not think that I may have forgot to put that 12 lead in, but there was some arrhythmias identified where she was having a lot of ectopy, and some of them were non-sustained, concern for non-sustained VTAC. Because of that, they placed her on defibrillation pads. Um, 15 minutes into it, they got another. Actually, I guess these are the EKG. These are the EKGs. I was thinking that these might be the hospital EKGs, but let me see. So here's the initial EKG. She has a little bit of ectopy. It looks like unifocal, otherwise narrow complex. And at 15 minutes, they get another set of vital signs. She's known to be tachycardic, even more so at 117. Blood pressure maintains at 118/77. Um, At 19 minutes, they initiate transport. They give her full dose aspirin as there were no contraindications, and she was complaining of chest pain as well. 20 minutes, they get another set of vital signs. Her tachycardia is improved to 110. Her blood pressure is 109/72. Respiratory rate was not recorded, and her room air sat was 98%. At 21 minutes, they start a line. They administer approximately 650 mLs of fluids throughout her transport. At 24 minutes, they trial one nitroglycerin. And at 26 minutes, they give her 80 micrograms of fentanyl. At 30 minutes, they repeat vital signs. She's now heart rate of 87, blood pressure maintains at 113/60, respiratory rate of 20 documented, room air sat of 99, and they document a blood glucose of 139. And then the number that's partially obstructed is her temperature, which was 98 and change. They get another 12 lead. And this 12 lead shows bigeminy unifocal with some other less frequent ectopy. What they documented was that given the rhythm of non-sustained VTAC, that that the patient appeared to be stable, and her symptoms did not appear to be dramatic or what they felt was unstable. They elected to not treat her arrhythmia and to treat her with just IV fluids, as she probably was dehydrated given her reports of nausea, vomiting for upwards of a week. They gave her another 50 micrograms of fentanyl en route at 35 minutes, and they repeated her vital signs: 98 for heart rate, blood pressure 112 over 76, no respiratory rate recorded, and SATs of 98% on room air. At 41 minutes, they arrived to the hospital. There was no Pulsera report when I looked this up, so I'm not sure if they notified by radio. In review of this pre-hospital management, I thought there was quite a bit that was done very well, as did Dr. Mocht, as he referred this case to me for case reviews. So early and repeat vital signs, early and repeat 12 lead, documentation of the patient's past medical history, as well as the events leading up to her initiation of 911, the decision making with chest pain, or the treatment of chest pain, 12 lead clearly way early before 10 minutes, and the attainment of an IV, as well as a room air sat and or SpO2 is required in our KPIs, and then management of her pain with nitro and aspirin, and fentanyl. The decision making in the documentation that they did not decide, they were prepared for if she decompensated, so they had defib pads on her, but no need to treat her with any antiarrhythmics at this point, as she appeared to be stable, and that decision was to be more supportive with IV fluids. And then making sure that whenever we're giving narcotics to patients, that we need to be recording their vital signs, respiratory rate, as well as an SpO2. So I have it in areas for improvement because I have only one respiratory rate documented, but otherwise this was a really well documented and managed case. Does anybody in the audience have any questions or
Just say I agree with that. And it would be very easy to kind of be tempted into treatment, but this woman was having very frequent ectopy, but it was all non-sustained. So just the thought process there, ready for the worst, but just watching at this point.
Thank you. So her ER management, they got basic labs. They found that she was hypokalemic with a potassium of 2.9 and a magnesium 1.6. Um, they did get a 12 lead. They noted that she had PVCs, also narrow complex. Let me see if I can move this for me. Nope. So her QRS is narrow. Her QTC is noted to be pretty prolonged at 523. Then there we go. They identified that she has been taking Mounjaro or tirzepatide, which is a GLP-1, and I believe it's a combo GLP-1 antagonist and I can think of GP1 or GP, but either way, they also did a CT of her abdomen because of her complaints of epigastric pain, which was, I think, essentially her chest pain. That was read as unremarkable for anything acutely going on with her. And then they started her on, so they admitted her to the hospital. She was admitted for 2 days. They did supportive management, repleted her electrolytes, and started her on a proton pump inhibitor due to concerns for dyspepsia. There was some question about opioid-seeking behavior, but otherwise she was discharged with an uneventful admission. So I thought this might be a good time to talk about GLP-1 agonists. As you might be seeing more and more patients that you come across with taking this medication. So historically, it was started as treating type 2 diabetes in the event that metformin wasn't meeting their goals. So now You might see patients getting this for type 2 diabetes or to treat their obesity or for pediatrics if they have nocturnal incontinence. But so specifically, if they can't tolerate metformin or have a hypersensitivity to metformin, they might be on a GLP-1 agonist. If their A1C is greater than 1.5% towards their target, 1.5 from their target, if their A1C doesn't meet their target in 3 months, or in cases of obesity. I listed a couple of the medications under the GLP-1 agonists, such as exenatide, lixisenatide, liraglutide, abiglutide, dulaglutide, and semaglutide. The ones in italics are the ones that you're more likely to see. They're more popular, liraglutide and semaglutide or Ozempic. The mechanism of action for these drugs is that they stimulate the insulin secretion after a patient has taken anything in that's a carbohydrate that increases their glucose, and then they have effects. Their effects can be delaying of gastric emptying, and it also inhibits glucagon production. So these patients tend to, especially when they start these medications, have nausea and vomiting, and this might be related to their delayed gastric emptying. According to the studies, it is in comparison to placebo that it promotes approximately 2.9 kilograms of weight loss. It also has some other positive effects, such as lowering cholesterol and blood pressure, both systolic and diastolic blood pressure. The other positive effects is that it can improve the ejection fraction, it can improve the contractility and the cardiac output for these patients, and it's associated with improved coronary blood flow and decreased risk for cardiovascular disease. Um, it also has effects to increase glucose uptake by the muscles and decrease the amount of glycogen stores, and it causes patients to feel full earlier than they would normally without this medication. This can be administered either daily, where some of the formulations are twice daily, and as well as once weekly. You're probably more likely to see a patient that administers it weekly, as they're more likely to be compliant with the injections as they're not as frequent. Although there's been recently an FDA approval of PO administration of this drug class. The adverse effects of this medication are related to nausea, vomiting, and diarrhea. The nausea and vomiting can lead to patients being non-compliant, and that's why they're supposed to slowly increase their dosing. If they're dehydrated enough, it can lead to renal failure. And then the contraindications to prescribing for this medication is that either they're known to be sensitive, it should be stopped on anybody that is pregnant, and then anybody that has a severe GI disease, such as significant gastroparesis or inflammatory bowel disease, and then patients that develop pancreatitis, as this can further complicate their pancreatitis course with like hemorrhagic pancreatitis, and then anybody who develops renal failure. This medication is eliminated by the kidneys, so renal failure would be an issue. So you shouldn't be seeing this in a patient that is a dialysis patient. And then as for our protocols, stable tachycardia, if the patient does not have signs and symptoms of poor perfusion caused by this dysrhythmia, then you really shouldn't be moving forward for aggressive treatment. In regards to narrow complex, which this patient had, getting a 12 lead, noticing that the QRS is narrow, and if the heart rate is greater than 180, this patient did not meet that criteria. And then if they did, it would be consideration of non-invasive first, such as vagal maneuvers, administration of adenosine. If it's irregular, then you should consider other causes. Is this compensatory to another issue such as sepsis, shock, or dehydration? And if you felt that that wasn't what was going on, as we would be more likely to treat them with IV fluids to manage what might be AFib or aflutter with calcium channel blockers. Have your all doses of adenosine should be reduced to half in the following clinical settings. Any patient that has had a cardiac transplant, who are carbamazepine or dipyridamole, and then anybody that you're giving adenosine through a central line. Question for the MPD group, would that also be considered for a PIC line, or is that just a central line?
I would interpret a PIC line as being a central line.
Okay, so I think that that'd be more likely for us in the pre-hospital setting of having a patient that has like a tunnel catheter or a PIC line. Do not use adenosine or calcium blockers in patients with WPW in AFib with wide complex may initiate rapid ventricular response, and then adenosine should be used in caution with asthmatics or any patients with reactive airway disease. Just kind of reviewing the notes and precautions as we tend to maybe not read all of them as an opportunity as a refresher. In patients with with tachycardia, particularly with history of AFib or aflutter, evaluate for possible other causes, as we don't want to be managing their compensatory response to a primary problem with antiarrhythmics. We want to manage their symptoms or their findings in regards to their primary issue. And then calcium channel blockers do not treat AFib like filter, but decrease ventricular rate. So it's really just rate control as opposed to consideration for cardioversion. They may cardiovert spontaneously because they got a calcium channel blocker, but it's not to terminate that rhythm. If the patient's unstable, which this patient wasn't, then we would be considering synchronized cardioversion with ideally some type of benzo to help facilitate the shock. But if the patient is truly unstable, we're going to be moving quickly to making them stable with potentially holding on Versed if it's not readily available. You can repeat the cardioversion if it's refractory, and if you still have no conversion after electricity, you should be giving an amiodarone at 150 over 10 minutes and considering repeating the cardioversion times 2 for a max of 200 joules. If still reoccurrent, amiodarone is recommended at another 150 over 10 minutes, and if you feel that your patient has multifocal tachycardia, such as torsades, magnesium would be indicated. If you are successful in converting your patient with either meds or with electricity, make sure you get a 12 lead if you haven't already, but ideally you get a post treatment 12 lead too. And then thought that it might be a little helpful to kind of remind us about the joules administered for cardioversion. So wide irregular defibrillation dose is not synchronized, and any tachydysrhythmias, we start at 100 joules and we increase to 200 as necessary. If refractory unstable tachycardia, you can double the dose, the initial dose to 200 joules. I think that's the big ones there. And that's it. Anybody have any questions about case 1? Great.
I think that's a great review. I just want to underline, like, these drugs are becoming really, really common. And so although the rate of side effects is relatively low, there are a lot of people taking them. So I think it's likely that we're going to be seeing more of this. Primarily going to be stuff like this, like the electrolyte abnormalities, but we've also seen some cases of pancreatitis, some other GI pathology with these medications. The other issue is that because the demand for them is so high, a lot of patients are getting them from compounded pharmacies. FDA has issued a warning about this. It can be safe to get from a compounded pharmacy. You just need to make sure that you're getting exactly the same thing as you would be getting if you're buying the drug whole from one of the pharmaceutical manufacturers. And then the other issue with these drugs is that they're dosed by injection once weekly, so they have a very long half-life. And I've seen patients who, inadvertently overdosed because they administered too much of the sub-Q injection. Got a patient give like a month's dose in a week, and ended up needing to be hospitalized for a week because the side effects of these medicines are so, they're such long-acting drugs.
Absolutely. And I would also say that they're costly, and if they're not covered by insurance, a lot of people may resort to picking them up out of country, and then there's absolutely no oversight in their administration or in their symptoms, as it's not a medication that's prescribed by um, a, a physician or PA or nurse practitioner. They're just picking them up and administering them in their interpretation of it. All right. Thank you. On to case two. This is a case of a 52-year-old male that was found outside in a cold environment in his underwear. This is not the patient. The patient was unconscious, unresponsive. They found that his airway was open, but he wasn't protecting it. He was cool, pulseless, with no active bleeding in a cold environment. The documentation was that it was a 40-degree day that was raining with kind of slushy rain, so on the verge of snow. Vital signs were obtained immediately upon arrival. There was no documentation of heart rate or blood pressure, but in the narrative, it stated that the patient had no pulse. There was no respiratory effort on his own, and his end title was 45. Past medical history provided was that he has a history of depression and high blood pressure, unknown medications, and that the mother had went in and checked on him because she hadn't been able to get in touch with him for a week. She found him outside in the elements, and she did not initiate bystander CPR. The call started at 11:07 in the morning. They tried to place an eye gel, but this was unsuccessful because the patient's jaw was reported to be stiff. This is the initial rhythm, which appears to be PEA-Y complex-ish. At 1 minute, they decided to bag him, and my understanding is that they did do classic or regular CPR in the interim of getting him on the Lucas. At 2 minutes, an NPA was placed. At 3 minutes, Lucas was started, and at 9 minutes, an IO was established, where he received 900 cc's of IV fluids throughout the course of his encounter with EMS. They document that his arms were stiff, that there was trauma to his knees, and that his pupils were dilated, non-reactive. At 11 minutes, they gave the first milligram of epi. At 13 minutes, they checked a blood glucose, which was low at 63. At 17 minutes, they administered D10 and another milligram of epi. So a second epi comes in at 17 minutes. And then they document that they decided to transport this patient as they suspected he might have been in cardiac arrest secondary to hypothermia based off of the environmental conditions, as well as their exam, the stiff jaw and cold extremities. They initiated transport at 18 minutes. At 20 minutes, he did achieve ROSC, albeit it was for a short duration. And they did document that they initiated warming inside the ambulance, turned the warmers on, turned the thermostat on in the back of the ambulance. I believe that they documented in the narrative warming packs in the groin and the axilla, a blanket on him. And at 22 minutes, his vital signs after ROSC was a heart rate of 107, a blood pressure of 145 over 115, no respiratory rate recorded, no SpO2, but end tidal was 33. At 25 minutes, they placed him on a nasal cannula, but unfortunately, he lost pulses. And at 26 minutes, they resumed CPR and gave him 1 milligram of epi. They repeated his blood glucose after receiving the D10. It was 113 milligrams per deciliter. And at 28 minutes, there was a rhythm change. I have both shocks here, but that they interpreted it as VFib. They shocked him at 200 joules, and then they shocked him again 2 minutes later at 300 joules. And administered at 31 minutes, 300 milligrams of amiodarone. At 32 minutes, he receives his 4th milligram of epi. At 33 minutes, he has a brief period of ROSC. Blood pressure is documented as 162/78, heart rate is 168, and respiratories of 10. Stats now at 65%, and end-tidal 18, but unfortunately he decompensated again, and they shocked him with 360 joules and gave him another 150 milligrams of amiodarone for VFib. At 35 minutes, they reassess him again, having a ventricular dysrhythmia. So they defibrillate him at 360 joules, another milligram of epi. And at 37 minutes, they reassess again a ventricular arrhythmia, 360 joules. They defibrillated him again, and I think a total of 5 times. So 2, 3, 4, 5. And at 40 minutes, they arrived to the hospital. The Pulsar notification is that they have a unknown downtime, no ROSC was outside, cold, low temperature. CPR started at 11:05 for PEA. And blood glucose documented 63. One of the things that's really helpful when you guys enter in the Pulsera is let us know if you have a definitive airway. When we get something like this, we assume there is no definitive airway, which is accurate in this particular case, but it allows us to determine if we need to have the video laryngoscopy, which, if you're familiar with ours, is an entire stand at the bed, at the head of the bed. So if we know that we don't need to, we don't have to prep it, and we can be prepared to manage the other issues with the patient. So also helpful in the Pulsar notification. In review of the case from the pre-hospital side of things, the really well-managed portions was the decision-making to transport this patient due to concern for hypothermia, the management of hypothermia in the sense of heating blankets, heating pads, or heating packs, and then management of his hypoglycemia, and then cardiac arrest. They noted, one thing I forgot to mention is that in the initially, when they defibrillated him 28 and 30 minutes into it, there was question to if the pads were appropriately placed, or maybe that they would consider an alternate placement of the pads to try to help facilitate getting him out of his ventricular arrhythmia. So that's what I mean by pad placement. And then areas for improvement. There was a lot of errors in the documentation, but that was just grammatical. So make sure you review your narrative, and then communication with Pulsera, notifying if the hospital needs to be ready to also intubate the patient, and then any adjustments specifically for hypothermia or hypothermia arrest, which we'll talk about here. The patient arrives to the emergency room. They have him in a C-collar. They state that they were able to get ROSC for about 90 seconds prior to arrival to the hospital. And initially, they note that his cap refill is particularly prolonged, greater than 10 seconds. They did intubate him on first pass with video laryngoscopy. They initiated CPR for approximately 20-some minutes between 11:46 and 12:07. During the resuscitation, they shock him 3 more times for VFib at 11:52, at 12:01, and 12:04. They document that although the patient's in cardiac arrest and cold, they don't think that his primary problem is hypothermia, so they don't really initiate aggressive warming. And I think that that might also be why they had managed him more like a medical cardiac arrest as opposed to an environmental cardiac arrest. Initial labs were notable for pretty profound acidosis with a pH of 6.79. His CO2 was pretty elevated as well at 165, suggestive that not only was he not ventilating, but that there could have been some assistance in decreasing his ventilation or increasing his ventilation rate. And then his potassium was elevated at 6.2 and his lactate was elevated at 8. So in conjunction with his cardiac arrest management, He also received bicarb, lidocaine, and magnesium, as well as insulin and IV fluids. Unfortunately, his resuscitation did not yield ROSC, and because of his downtime as well as the lack of response, he was pronounced in the ER.
Forgive me if I missed it. Were they ever able to get a core temperature?
No, they. It's a very good question, and the vital signs were never documented despite the time in the ER. So under our vital sign tab, there were 0 ones. So I don't know what his core temperature was. And it wasn't documented in any of the narrative sections of the notes.
Got it. Thanks.
Yeah. So although the hospital felt that this was not a case of hypothermia, I thought it'd be a good example to review. Although we're trying to move out of winter, despite the the current events in our temperature lately. So hypothermia is an unintentional decrease in temperature below 34 degrees Celsius or 95 degrees Fahrenheit. There are 3 stages. Here is supposed to indicate the Celsius on the left-hand side of the chart. So initial 32 to 35 degrees Celsius, the patient will develop vasoconstriction peripherally, and their brain will tell them to shiver as well as to release some catecholamines to help facilitate um, efforts to rewarm themselves. They may present with confusion, inability to speak, ataxia, as if they appear to be under the influence of alcohol, and impaired judgment. At the next stage, at 28 to 32 degrees Celsius, they're no longer really shivering, and the catecholamine release returns back to its baseline. They'll have some slowing of their central nervous system processes, as well as their heart rate and blood pressure and respiratory efforts. Heart rate can be 50% of the normothermic levels. Just maybe pretty profound bradycardia. They may feel like they're warm, but that is just a factor of their altered mental status. So they may start to try to undress themselves. And then there's a condition or a pathophysiology of cold diuresis where they're trying to urinate increased amounts of fluid that I guess basically that comes to their bladder, so they're really urinating potentially quite a bit, and then they may become even more profoundly altered. At less than 28 degrees Celsius, they're no longer urinating. That cold diuresis stops. There could be some impairment further of their central nervous system processes, which can lead to coma. Their respirations decrease and they become even more profoundly bradycardic. They have a greater chance for arrhythmias, and their heart rate can be 20% of what it would be under normal temperature. So they may be very, very profoundly bradycardic. In regards to hypothermia management, we want to gauge the suspected severity stage. So kind of think of, are they shivering? Are they not shivering? Are they trying to take their clothes off? Are they what's their heart rate like? And um, those are kind of your basic temperature assessment. Our thermometers don't usually work very accurately under 34 degrees Celsius. So rectal temperature really is, or I guess I should say peripheral temperatures are not as accurate under 34 degrees Celsius. So rectal temperatures, or in the hospital, thermistor Foley catheters are really indicated to get an accurate representation of what their vital signs or their temperature is. Assess their level of consciousness, assess their hemodynamic stability. And then when we manage these patients, we're going to be using our basic medical principles such as ABCs, supporting them. The differences in regards to hypothermia management is that we're going to try to prevent them from getting any colder and to start their rewarming process. We want to handle them really gently as their cardiac stability is irritable, in that pretty even mild jostling can lead to deterioration of their rhythm into ventricular fibrillation. We want to actively warm them in certain cases if we have the means to do so. So for us in the pre-hospital setting, it'll be heat packs, blanket, warm fluids if possible, and turning on the thermometer or the turning up the heat in the back of the ambulance. And then getting an EKG. If we do find that the patient doesn't have a pulse, we want to make sure that we're checking that for 1 minute. Remember, if the patient is profoundly hypothermic, that their heart rate may be only 20% of what it would be at normal temperature. So making sure that we give them time to be able to feel a pulse and to assess it for enough that we get an accurate representation. In that if we are talking about these patients can be very irritable, starting CPR unnecessarily could lead them to actually becoming further unstable. Pharmacokinetics, we know that in cold environments that these patients are not metabolizing as quickly, so we're trying to reduce the amount of redosing of meds, especially as they start to rewarm. They may still have quite a bit of the initial medication management that was administered. So we could find that we are actually overdosing these patients. So we tend to recommend less aggressive intervals of treatment. And defibrillation, usually the recommendations for profoundly hypothermic patients is to defibrillate them one time and get their temperature up before further defibrillations. History is really helpful to gather, and then making sure that your handoff report of your concern for hypothermia is addressed. This is an EKG showing a patient before they become profoundly bradycardic and or in cardiac arrest, representing Osborne waves. These are upwards deflections above the baseline with a J point above the baseline. I forgot what temperature you would see the Osborne waves. I don't know if anyone on the call might be able to put in the chat or unmute themselves, and if they know what temperature that this usually represents themselves. And then
And
go
it's
ahead.
not like there's a hard and fast correlation. I mean, it's something you might see with moderate hypothermia, but I think I wouldn't use that to gauge what temperature you're at.
Oh yeah, definitely. Agree. As in, not so cold that they're in cardiac arrest, but being cold, I would probably say. Southwest region protocols for hypothermia and cold exposure. We're going to be using our universal care precautions. We're going to remove any wet clothes and protect them from further environmental exposures. This might go without saying, but we're not going to remove them from their wet clothes out in the elements. We want to do that in a controlled environment. So if you find that you can't put them in dry clothes or protect them from the elements, get them to where you can do that first so that they don't further become more cold. Assess the ABCs, allow up to 60 seconds to confirm respiratory arrest, pulseless cardiac arrest, or bradycardia. Under patient perfusing, monitor EKG and pulse oximetry. Handle the patient really gently to avoid VF or ventricular fibrillation. Institute rewarming procedures such as warmed oxygen and humidified oxygen, warm packs, heated blankets, warm ambulance. And then in regards to warming their core, you want to use warm IV fluids, 300 mLs, avoid overhydration, and then heat packs to the groin and axilla. If the patient does develop cardiac arrest, you want to begin CPR. The hypothermic heart may be unresponsive to cardiovascular drugs, pacer stimulation, or defibrillation, so rewarming is really the priority in this type of situation. If the core temp is less than 30 degrees, equal to or less than 30 degrees Celsius, no more than 3 defibrillation attempts prior to rewarming. The interval for medication administration should be doubled until they're normothermic. And then continue the rewarming procedures while en route to the hospital. Other considerations, if the patient's unconscious, go down your altered mental status and coma protocol. So blood glucose would be indicated. And then for a less severe presentation of cold exposure, it would be frostbite. Protect it with dry dressings. Do not rub frostbitten areas and permit only gradual rewarming by room temperature out of hospital. And then patients that are at risk or anybody that can't control their temperature, either because of baseline pathophysiology, so maybe our elderly patients or patients that have that take medications that affect their ability to maintain their homeostasis, or patients under the influence of drugs or alcohol, or just our elderly patients that are demented who don't have any recognition of what's going on, as well as patients um, that are affected by financial issues such as low-income families where they can't turn the heat on in their homes. Um, Hypothermia may be preceded by other disorders, so make sure that you're considering that, such as trauma, overdoses, or substance use. And then if your patient is dead in the field and meets the criteria, online medical control would be indicated. All right, anybody for case 2?
Just one note on measuring temperatures, like your tympanic and ear thermometers are going to be the least accurate, particularly in hypothermic patients. Axillary would be your next best bet, and then oral for a conscious patient. For hypothermic, that's going to be your best bet in the field. But I think for this patient, you could consider an axillary temperature if you want to get a rough idea of where you are.
Absolutely. All right, so our next case is a twofer and representing kind of the same teaching point. So the first one is of a 60-year-old male who was shot. He was unconscious, unresponsive when they arrived. He was apneic and he was not protecting his airway. He had initially there was concern that he didn't have a pulse, but a few minutes afterwards, another agency arrived and confirmed that he did have a carotid pulse that was weak. There was some active bleeding from his GSWs, but nothing that was from the documentation, anything that was concerned for hemorrhage at that point. At 2 minutes, they document that his heart rate was 40. They're unable to get a blood pressure, and his respiratory effort was 0. Unknown past medical history, meds, or allergies, in that the history was that he was an officer involved shooting. This occurred at 1:34 in the morning when they made contact. They documented that there was a delay to patient care due to access because of law enforcement vehicles blocking the um, ingress, in that they found the patient on the ground with bystander CPR being performed by law enforcement, as well as an AED placed, in that they documented that the patient's arms were still cuffed behind him. At 2 minutes, the vital signs as mentioned. At 5 minutes, they started to ventilate him with a bag valve mask, and at 6 minutes, they attempted to place an eye gel, but that was unsuccessful. They noted that the patient had penetration wounds from his GSW at the navel, at the genitals, and 2 in the back, as well as 1 on the left anterior side of his chest. They placed a chest seal. At 9 minutes, they removed the cuffs. They put him on a backboard and moved him away from the location he was at. And I think that that was based off of the fact that they documented there was a gun on the near the patient. At 10 minutes, they noted that his heart rate now was 26. They still weren't able to get a blood pressure, and they were ventilating him at 10 times a minute. At 11 minutes, his heart rate had further braided down to 10. They still couldn't get a blood pressure. They documented that he was not breathing at all on his own still, and they initiated CPR. At 12 minutes, online medical control was consulted. I'm a little unclear about why they documented that the lung sounds were auscultated after online medical control. I'm not sure if that was just to confirm, but nonetheless, that's what they documented. At 14 minutes, they have no pulse, again, no blood pressure, and his SATs are documented as 79 with supportive management, and he was pronounced in the field at 14 minutes after initiation of patient contact. No pulse error was found because the patient did not transport. And in regards to this particular case, that I thought that the management of a trauma arrest was pretty good, ventilation, as well as placement of a chest seal, in that they documented that they couldn't get to him as quick as they would have liked. And then areas for improvement is that what we'll talk about is our hat resuscitation, hemorrhage, airway, and potential for pneumothorax. The second case is a 43-year-old female that had been involved in a motor vehicle crash. When they arrived to her, she was complaining of shortness of breath and that she hurt all over. She was the driver still in the car requiring extrication. She was alert, although it sounded like she was a little bit out of it. Her airway was open and she was protecting. And initially, they noted that she was pale, ashen, without any obvious signs of bleeding as she was still pinned in the vehicle. At 3 minutes after patient contact, her heart rate was documented as 120, no blood pressure was recorded, and a respiratory rate of 20 was documented. They also recorded her to be pretty large in body habitus at 136 kilograms. Her past medical history and her meds were unknown, and the history that they documented was that she was a driver of a crossover vehicle. There was pretty significant front end damage on the left side, with greater than 18 inches of intrusion. Her airbags did deploy. They suspected she wasn't wearing a seatbelt as it was not cut off of her, and that she was pinned in the vehicle by the dash and the door. They noted that the steering column was damaged and there was some damage to the windshield as well. She was placed on a non-rebreather prior to transporting agency's arrival. This is 3:17 in the afternoon. Uh, they wrote that she was perseverating, she was pale and ashen, her breath sounds were present but diminished. After they were able to extricate her out 5 minutes after arrival, and place her in spinal precautions, they noted that she had ecchymosis to her upper abdomen. While she was still in the vehicle, they documented that she had normal upper extremity exams, and they suspected a left shoulder injury. Once they were able to extricate her out, they noted that she had some pretty extensive lower extremity injuries, such as an open right tib fib and what they documented as bilateral open femur fractures. At 9 minutes, they start a line. They give her 200 cc's of IV fluids. At 11 minutes, they document a full set of vital signs at a heart rate of 122, blood pressure 80 by palp, respirators of 20, and room air sats of 99%. They initiate transport at 12 minutes. They document that they tried to place a tourniquet, but because of her body habitus, it was difficult. And they note that there was no pulsatile bleeding, so I think that they're indicating that they didn't think that it was, although they wanted to place it, that it wasn't imperative, as they didn't think that there was extensive bleeding coming from her wounds. At 15 minutes after she's transported, they noted that her heart rate decreases to 40. Her mental status also decreased. Her respiratory rate was 15, and her room air sats, or her non-rebreather sats, were 87, so they placed her on a bag valve mask. At 16 minutes, she lost pulses, so they initiated CPR. And at 17 minutes, they obtained vital signs. She's still pulseless. She's now hypoxic, even more so at 44, and they check a blood glucose, which is 96. At 18 minutes, they administer 1 milligram of epi. They intubate her with a 7.5 ET tube. They document that her breath sounds are clear, and they're resuming CPR. At 19 minutes, they are still doing CPR. She's still pulseless. At 23 minutes, she gets another milligram of epi, and online medical control was consulted. And at 30 minutes, they document time of death. There's no pulsaric case, as this patient did not arrive to the hospital. And in review of this case, there was a lot of really well-managed portions of this: early vital signs, limited scene time following extrication, IV access, maybe a possibility of a second line, and maybe more aggressive IV fluid administration, as she received 200 cc's. They did get serial vital signs. They considered bleeding control, and warned and documented that the difficulties in getting that and the overall concern of her bleeding, as well as they managed her airway appropriately and increasingly more aggressively as she further declined. Areas for improvement would be hat resuscitation. And then for controversies, I wrote after discussion with MPD's office, field termination after initiation of transport. I'm going to briefly talk about that here as there's not any other sections that we'll be talking about it. So ideally, we would not initiate transport in a patient that we thought we were going to be terminating, but as we know in this particular case, she had a pulse and she lost it as we initiated transport. And although we typically do not call for a field pronouncement while we're transporting a patient, we thought that this was appropriate as this was an agency coming from quite a distance to the hospital with, I don't know if it was 20 or 30 minutes projected to time to the hospital. So given that she's already arrested and we're talking about that she is already 14 minutes in cardiac arrest, another 20 to 30 minutes in cardiac arrest would not be helpful for her resuscitation. And then the other point is that if you end up transporting a patient that trauma arrests, that we would still want you to go to a trauma center to receive that patient at a trauma center as opposed to the closest hospital. So I did not find specific details about HAT resuscitation in my research, but there's lots of data about managing hemorrhage, managing reversible changes such as tension pneumothoraxes, and managing airway compromise, which is essentially where our HAT protocol is coming from. So it's under the death in the field portion of COPS. Unwitnessed trauma arrests is almost uniformly fatal when EMS arrives due to severe hypovolemia, hypoxia, or tension pneumothorax. Although this patient didn't quite meet the criteria as this wasn't an unwitnessed, it was a witnessed trauma arrest, but the same principles do apply. So witness trauma arrests, you're going to manage any external bleeding, which they attempted to do so, as well as consider applying a pelvic binder if there's pelvic trauma, given the fact that she was an obese woman who was unrestrained in a motor vehicle crash. There is a high probability for pelvic trauma, but they may have met the same difficulties with her body habitus with the pelvic binder. And then administering IV fluids. Ideally, it'd be blood, but we don't have that as an option in our county. So at least a liter of lactated ringers. And A for airway and oxygenation, ensure adequate airway patency and effective oxygenation. This doesn't necessarily mean that every patient needs to be intubated. If you're ventilating the patient appropriately with a BVM or ideally an iGel, a supraglottic airway, you don't have to necessarily replace that with an ET tube, but that would be the definitive airway management. And then performing bilateral needle decompressions if indicated. A patient that both patients actually that were showcased in this particular protocol or this particular case reviews both had the potential for chest trauma with the GSW to the chest, as well as the patient that may have taken the steering wheel to her chest. So I believe that it would be indicated for both of these patients to have bilateral needle decompressions, especially if we're talking about that they have arrested and we're potentially going to be leaving them on scene. Trauma patients who are pulseless and apneic on EMS roll are considered dead in the field unless there are extenuating circumstances, such as a medical cause or hypothermia. And for patients found in VFib or pulseless VTAC on EMS arrival, suspect a medical event and treat per the VF pulseless VTAC protocol. So really trying to avoid management as like a medical cardiac arrest so patients in trauma arrest don't typically get administration of cardiac stabilizing drugs unless you think that it was a medical cause. For patients who deteriorate to PEA or asystole on scene, begin CPR while instituting the HAT protocol, which we talked about above. If ROSC is obtained, transport to a trauma center. If ROSC is not achieved, declare dead and contact online medical control. If the mechanism of injury appears inconsistent with the patient's condition and not severe enough to induce traumatic event, consider a primary medical cause. Anybody have any questions or concerns about this particular case, these cases? All right, I'm hearing nothing. I'm going to move forward. Last case, thank you guys for your time and attention. This is of a 20-year-old female that EMS gets called for altered mental status. They document that she's in and out of consciousness and very aggressive. So they were dispatched to a suicidal party who was altered. She was awake initially with them. Her airway was open and she was protecting it. Her pulse was pink, warm, dry without any signs of bleeding. And at 14 minutes after patient contact, they documented a heart rate of 154, a blood pressure of 137/77, a respiratory rate of 22, and room air sats of 95. Her GCS is documented as 11. Her past medical history includes depression, and her meds include venlafaxine and amitriptyline. The history provided to EMS is that they think that she overdosed on amitriptyline, approximately 45 pills. They said that her last known normal was 2 hours ago. They don't know when she may have ingested this. And they get this call around 12:21 when they make contact with her. At 9 minutes, an IV is established, and at 14 minutes, the vital signs that I just reported to you were documented. 19 minutes, she is placed on a nasal cannula at 8 liters. And at this point, I believe this is one of the times where she is actually going, she had a seizure at 14 minutes, and that's why they gave the Versed. At 19 minutes, they place her on a nasal cannula, and at 24 minutes, they get a 12 lead, and they administer 20 milligrams of etomidate as they're moving forward with RSI. At 25 minutes, they give her 100 milligrams of succinylcholine. At 26 minutes, they perform a successful intubation with video laryngoscopy. And at 29 minutes, she receives 50 micrograms of fentanyl for her post-intubation sedation. And at 39 minutes, they initiate transport. At 49 minutes, she arrives to the hospital. They document that they did not give Versed for post-intubation sedation because she'd already received Versed for her seizure. The Pulsera notification is that she's a red patient. The information that they provided was that it was a suspected amitriptyline overdose and in a suicide attempt. They don't know how many meds that she had taken or how long she took it, how long ago she took it, and that she was tachycardic. They documented that they did secure her airway with a ET tube, and they document that her heart rate's 115, although that 158 probably would be a little helpful knowing the severity, but either way, blood pressure 134/48, pulse ox of 99, respiratory rate 18, GCS of 3, assuming that's probably her intubation, and then a blood glucose of 157. In reviewing this case, airway management of this patient with first pass and video laryngoscopy, I do think that there was some areas for improvement. Blood glucose was never checked. Although I'd probably put in the good is that they did get a 12 lead. It was pretty late in the initial presentation, 24 minutes into the case, they got a 12 lead, which means that they missed an opportunity to see if she was having worsening conditions with her ingestion, as we really want to get serial EKGs in these cases to see if there's further QRS or QTC prolongation. Consideration for tricyclic antidepressant management overdoses. This could be managed differently, and we'll talk about what ideally should have happened. Administration of rocuronium, as we don't know what her renal function is, and then goals with post-intubation sedation. So not only are we talking about pain management first through the use of fentanyl, but also Versed or ketamine, depending on what we have available to us. And then whenever possible, if there are medications that are available to bring to the hospital, to document or to obtain that pill bottle so that we know the quantity, not only the quantity, but also the concentration of the medication. So in the emergency. Go ahead.
Sorry to interrupt. Was
No,
the
no.
on the initial ECG, was the QRS wide?
Yes, it was, if I remember correctly, like zero point 0.1 millisecond. So QRS wasn't wide. It was like 0.11, I believe.
Got it.
Um,
Okay.
yeah, but it appeared to have missed that one in putting it in this case review. But they did do one 12 lead, yes.
Well, yeah, and you wouldn't necessarily even need the 12 lead just to see if the QRS was wide, because that's the key thing that you'll use in your treatment decision making.
Yeah. Although I would advocate to get a 12 lead. But yes. Um, so her 12 lead hospital arrival is 0.126 milliseconds. They gave her sodium bicarb, three doses at 150 milliequivalent total, with a subsequent QRS after administration of bicarb to 0.11. Another example of that, we want serial EKGs not just for the patient's ingestion, but also after we treat the patient, if we had treated the patient, so that we can see an improvement and know where our goals are. Her QTC was also prolonged. I believe I have an EKG. No. Um, Poison control was contacted after they initially managed her arrhythmia. They recommended using bicarb if the QRS is equal to or greater than 110 milliseconds. Her labs were significant for a low magnesium of 1.5 and a potassium of 3.5, which is essentially normal. She was admitted to the ICU on a bicarbonate drip, and she was hospitalized for 4 days before she was transferred to Rainier Springs. Because of her seizures, she did get an MRI of her brain. That was read as normal. Her EEG did not show seizure-like activity, although she was prescribed and started on valproic acid. She extubated herself on hospital day 1. So, an opportunity to talk about TCA overdoses. Uh, these patients are potentially prescribed if they have a prescription, or if they're obviously using someone else's. This would not be helpful. But anyways, they are prescribed tricyclics for refractory depression after initial, more safer antidepressants are administered, or for neuralgic pain, or for migraines, prophylaxis, and for obsessive compulsive disorder. The epidemiology of TCA overdoses is that there's 1.12 exposures in every 10,000, but that was data from 1992, so take that as a grain of salt for you. The pathophysiology of tricyclics in general is that it inhibits the reuptake of norepi and serotonin in the central nervous system, and that in itself can cause seizures. But when these patients take it in larger than prescribed dosing, it blocks the alpha adrenergic receptors, which can lead to hypotension. It blocks the serotonin centrally. It blocks the muscarinic receptors, which can lead to anticholinergic effects. So the red skin, the confusion, the tachycardia, the dry mucous membranes, more as your anticholinergic syndrome. And then they can also block the histamine receptors, so they can be more confused as well. In toxic levels, their heart is affected. So TCA TCAs work to block sodium channels, which further slows action potentials and membrane stability. So these patients will present with potential for heart block and bradycardia. Although the muscarinic effects of their blockade seem to override the bradycardia, so they do tend to be more tachycardic when you first are dealing with these patients. It also blocks the potassium channel, so it leads to QT prolongation, which could put them up for torsades. And then there's quinidine-like toxicity that further potentiates their hypotension, just like with their alpha adrenergic blockade. Toxic values are 10 to 20 milligrams per kilogram, and workup for these patients include a 12 lead. You may have heard of the terminal R wave with TCA overdoses, and that's an ABR when you have a small R wave, but a larger R wave subsequently. And remember, the R prime is the prime is the larger of the two similar presentations. So the small r versus the R prime. So terminal R wave and AVR can be helpful in determining if a TCA is involved. Vital signs for these patients, IV access because of their confusion, a blood glucose, basic labs, as well as other potential overdose labs. And then if the patient is that altered, they may need a CAT scan of their head as well. Management is going to be ABCs. The documentation in the literature is that if they've ingested a TCA in less than 2 hours, that they could potentially get activated charcoal if their airway isn't an issue. It's really important in managing these patients to avoid acidosis, as this can further lead to higher levels of toxic metabolites. So trying to make sure that you're ventilating them appropriately, you're managing any hypotension with IV fluids, and then seizure management in these patients as well. If their QRS is wide or they develop a seizure, you're supposed to administer sodium bicarb, and then supporting their hypotension with IV fluids. And if they're still hypotensive despite IV fluids, administering norepi, an alpha drug. And then if the patient doesn't respond to if the patient is bradycardic and doesn't respond to these management options, the consideration for pacing them would be indicated. And then in the hospital, we may consider intralipids because of the risk of toxicity and the amount of binding to the plasma proteins. One of the other things that I found in reviewing this particular case is that, or TCA overdoses, is that you want to avoid any sodium channel blockade, which we really don't have any in the pre-hospital setting of 1A and 1C type drugs, but we also want to avoid potassium channel blockade, which would be a type 3 drug, and that would include amiodarone. So if you're dealing with a patient that is suspected or known TCA overdose and you're reaching for amiodarone, you really should pause and maybe contact online medical control if you're thinking that you're seeing like AFib or something along those, or not AFib. If you're seeing just having if you're seeing like VTAC or VFib. And then for our Southwest region protocols, which is already listed here for TCA overdoses or Benadryl overdoses, if the patient is tachycardic and they have a heart rate above 110, if they have a dysrhythmia, if they have a widened QRS, or if they're seizing, that the way I interpret this is that sodium bicarb would be indicated if you're North Country, but if you're not North Country, you should contact online medical control, because the reason why I understand that bicarb is only for North Country is because of time to hospital. Am I interpreting that correctly?
No, I can clarify that. So
Okay.
if for those indications, bicarb is indicated for everyone.
Okay, so is North
We're
Country just for redosing? Is that what that North Country EMS is?
Correct, and we're clarifying that's not agency specific, that's time specific. So
Okay.
we would redose if you go 30 minutes, but that's only in there because that is the only agency that's likely to have that transport time. But the redosing is time specific, not agency specific. And the
Yeah.
sodium bicarbonate is indicated for everyone in the county for patients who meet those criteria.
Yeah. So when I reviewed this case, I read it as North Country, but I had said as a follow-up is that this is somebody who should get bicarb regardless. And if it's not in the indication, to contact online medical control to confirm that you can administer it. So agree. I'm glad that that isn't just North Country. And then if let's see here. They say magnesium sulfate, but it really, I guess I think of it as like QTC prolong. Oh, for wide QRS. Okay, here. Anyways, they say 2 grams for wide QRS. Although, is that I'll ask about that offline. And then Versed if they're having seizures. Anybody have any questions about case 4? All right, so in conclusion, maybe. So GLP-1s, we're probably seeing this more going to be for patients with weight loss. The chances for nausea, vomiting are high, especially if it's more aggressively dosed. And then with nausea, vomiting, you lead to dehydration, electrolyte abnormalities. Um, as for hypothermia, we're going to be talking about patients that need to be cautiously handled as well as monitored for at least a minute whenever you're doing pulse or respiratory checks. In that our protocols say for spacing out the administration of our drugs as well as no more than 3 shocks if we're dealing with suspected hypothermia, as well as the management of hypothermia being aggressive with warm saline, warm oxygen if possible, heating pads in the armpits and the groin, turning up the back of the ambulance temperature, and blankets. In review, we're also talking about trauma arrests that we are recommending HAT resuscitation. So IV fluids with a liter of lactated ringers, managing their airway, making sure that that's not contributing to their arrest, and consideration of bilateral needle decompressions if there's an indication such as trauma to the chest. And then as for TCAs, these are all the different names. Usually you can follow with anything that ends with a lean or triptyline. But these are patients that we really want to get a set of a 12 lead early on, in addition to vital signs that if they are seizing, if they, according to our protocol, greater than a heart rate of 110, comma, QRS prolongation, or we find them to be hemodynamically unstable, it'd be indicated to give them sodium bicarb as well as magnesium if their QRS is wide, and then administration of Versed if they are having a seizure. Okay, that is all I have for you guys.
Thank you.
Yeah, thanks.